It is a huge honor today to be interviewing Louis Malcmacher, my friend for probably close to 25 years. I've seen your lecture several times. All I can say about Louis is him and his wife are two of the greatest quality people I've ever met in my life, and you're always on the cutting edge. I mean, whatever the cutting edge of my career was 28 years, looking back, you were always 5 years ahead of it. And everyone loves your lecture. You're just a hell of a neat guy. How are you doing today?
Good, I'm doing great. And it's the Mutual Admiration Society. I was one of the first subscribers of the Farran report, okay? I mean, I've been following Howard Farran, who's just a genius in the practice management side, and he's a darn good dentist, too, which nobody knows about, I mean, they all know you practice, but you know your stuff all the way around. I just want to say, I'm glad. I was afraid that I would be underdressed here, because every time we lecture together, you're in a Hawaiian shirt, and I'm always in a formal suit and tie, but I got to go see patients soon, so I already put on a smock here, so I'm glad. I'm glad I'm not underdressed or overdressed. We're about the same today.
I can't tell you how many times I walked in to do my mic check or whatever before a lecture, and the president of the society invited me in saying, "So are you going to go back to your room and change?" And I'm like, "No, are you?" I've lectured in sweats and but anyway. But I want to say, but your background, we both have the background. I'll pan to mine for a second. The neatest thing about my profession is that all my friends are dentists, and dentists are all readers. I mean, I have spent the night in 100 dentist homes in 50 countries, and they always have at least 100 nonfiction books. All dentists are readers. And when you spend the night in someone who's not a dentist, a physician, or a lawyer, they have 3 books, and one of them's, they're all fiction. And God, I think the thing that I love the most about choosing dentistry is that all my friends are readers, and it carries over to their thoughts on politics, religion, society, economics. I mean, they're dentists. I mean, it's one of the most fun professions to be into just because all your colleagues are readers.
Right. Listen, we all love to be educated. That's why we went into dentistry. And listen, how many groups do you talk to that I talk to? I mean, everyone, we just love education. We love to read. We love to know things. I mean, we're people with toys. We love our toys, and we love to learn. And that's really what makes dentistry exciting. The dentists that I see, and I'm sure the dentists that you see all the time, they come up to you and they say, "Oh my God, I hate dentistry. I'm so bored. I hate it." And you ask them what they're doing, and they're like, "Well, yeah, you do fillings? Yeah. Do you do dentures? No, I hate dentures. Do you place implants? No, it scares me, that surgery." They don't do anything in their offices, but the dentists that are really successful are the ones that love to learn, because that makes life successful, and that makes life fun, and it certainly makes dentistry fun there too. That's why I like to be ahead of the curve. I like I love it when people tell me I'm crazy, but you know what? It's fun to learn. Let's bring some of these things into dentistry. It can't be the same old thing all the time. That's how you get bored, and that's how you get burnt out. You talk about that all the time.
And that was the first of many scoldings I got from our common friend Gordon Christian. He's a DDS, he's got an MS, he's a prosthodontist, but he's a PhD in psychology. And I wrote this article on lasers. This is back on the Farran report when you subscribed. By the way, the Dental Town magazine was the Farran report 5 years first,
right?
Because it was a print medium back then before the internet, where I'm sending you one thing, and it was from Farran. It was the Farran report. But then when the internet came out and became two-way. It was no longer about me. It was about a community, and I called it Dental Town and all that. But I wrote an article called Lasers. Does it stand for light amplification, stimulation, emission, or radiation, or losing all savings equals reality? And my MBA walnut brain was saying that you want me to buy a $50,000 laser to do what a $1 disposable scalpel blade could do? And Gordon read that, and he chewed me out. He said, "Look, Howard," he goes, "these guys get burned out. If they buy a toy, and it makes them happy, and it makes them want to go to their office and play, you can't even measure the return on investment of that." He goes, "Our problem is doing a repetitive task over and over, 8 hours a day, 5 days a week for 40 years. It's going to lead to burnout. Olympic swimmers have high burnouts because they say, okay, Lewis, you're a butterfly, so I want you to swim the butterfly an hour before school, an hour after school, 7 days a week from age 5 to 25. These guys get to the point where they can't even look at water anymore. And Gordon was telling me that to buy a toy, to be happy, to love what you do is priceless. So don't be knocking their toys. And then I'd watch my four boys in the sandbox of the bathtub, and if it was just sand or just water, they'd be in and out in 5 minutes. But if you threw a bunch of trucks and toys and pails, and the more shit you could throw in the bathtub, the longer they'd all stay in there till their fingernails got clean. That was the key. Go find 5 toys and throw it in the bathtub. So what is the what has got you excited? Why are you always happy and smiling? What's got you excited in dentistry today?
Well, first of all, let me just go to the toys for 1 second, because then it'll fold right into the answer there. What Gordon says is true, but your MBA background has served you very well, because it was okay when the toys only cost you a few $1,000s, but when they're starting to cost $50, $100, $150,000, you better be making the right choices, because that can mean bankruptcy for a dentist. So yes, we love our toys, but there's not an unlimited. When you and I first started dentistry, I could open almost 2 offices for $100,000, and now it's a single piece of equipment, right? I mean, so that now you better be making the right choices. They're all great for the right practice and for the right dentist. So here's what gets me excited, and I love the big toys there too. I mean, first of all, I love helping dentists, understand when are the big toys appropriate for that, but for me, because we've got 3 practices in Cleveland, Ohio, and we maintain a very low overhead because we really work hard at the whole thing. For me, and it's the thing that we teach all the time, it's what gets me excited is teaching dentists new skills with their hands that they can actually go out and produce dentistry for the rest of their careers. Because you buy it, and I'm all for technology, but you buy a piece of technology, and you and I both know every computer you buy is outdated by the time you bring it home and set it up. And technology gets outdated, and there's a huge cost to technology. But if a guy can teach you skills-based dentistry, and that's all the stuff that we teach, and Botox and fillers and TMJ and sleep and all those different things, and a million other things to come, that's what gets me excited. What gets me excited is making dentists really, really successful by giving them, teach a man to fish kind of thing. Because you can feed them all you want, but if you teach them to fish, we can really be. There are so many problems that we've got to face in dentistry, and a lot of challenges that, and I say this all the time, and actually I heard you say it, and it was one of your articles in the last few months in Dental Town there as well. If you're not going to expand your services and you're just going to be a teeth mechanic, then that's great, but you're going to be extinct as a teeth mechanic at some point. You've got mid-level providers coming out. You've got technology that can replace a lot of the different things that dentists do. There are a lot of political and technology forces that, my God, it's time for us to be doctors. That's what it is. We got to stop being teeth mechanics, because that really lowers our own self-esteem. There's a thread on Dental Town where I wrote and I posted an article about why dentists have low self-esteem. And this is one of the reasons, because we think we're only teeth mechanics. We're not. We're real doctors. And that's something you've talked about forever as well.
And what's amazing is you're so upbeat, even though you live in Cleveland and the Browns are only 2-3. So, I mean, Lewis is happy no matter what. Even though the Cleveland Browns can't deliver, he's still happy.
Right. When you're a Browns fan, you live with that. Hey man, there were times the Cardinals weren't doing so well. I remember those days very well.
The Cardinals always do great till their quarterback gets tackled and is out for the season, then they don't win a game after. So we're in the early stage with a healthy quarterback, so we'll be good for a while. So let's start talking about some things. What are your thoughts on TMJ and oral facial pain?
So TMJ and oral facial pain is one of the things that scares dentists the most. I mean, actually, I did a little video chat that I sent out a few weeks ago saying, these are the patients that give you diarrhea. I mean, these are literally the patients that dentists are scared to death of. And because they're not trained to treat it with simple, minimally invasive ways to go ahead and do that. This is such a typical scenario, and we all have had in our practice for a long time. Patient comes in with TMJ pain, bruxism, even something like that. We give them a bruxism appliance, and they're having some pain. We say, here, wear this for a few months and, and let's see what happens. Now, I don't know about you, but if I'm in pain and I go to a doctor, when do you want your pain gone, Howard?
Right now.
Right now. No, here's something. Wear this for a month, 2 months, and we'll reevaluate and see what's going on. And then the patient comes back. By the way, what bruxism appliance do we choose? Whatever our favorite is. Like, we don't give any thought to it. And they come back and you're adjusting it, and the patient's getting worse or not better or staying the same, and they're frustrated, you're frustrated, they spent a few $100s, and you can't wait for this patient to either move or die because, you don't know what else to do with them. Or better yet, you put them in ortho, do a full mouth reconstruction, and their pain is still no better. So, we've been doing things wrong like that, and that's why dentists are scared to death of these patients. And when you have 85% of all TMJ head and neck pain coming from the patient's muscles in the head and neck and in the face, it's time to take a step back. And these are evidence-based studies that go back years. For this. You know what? How about we take a step back, learn to identify these muscles, treat these muscles. These are muscles that we work with all the time in dentistry. They teach them in every, general dentist oral facial pain residency around the country and around the world. I mean, let's teach some skills-based, ways to treat this with trigger point therapy, which has only been around for 50 years. And I was lucky enough to learn it in dental school. Botox is great for relaxing muscles. That combination, we get rid of facial pain patients that are coming in with a bag of bruxism appliances, from 10 different dentists. It's really just amazing, and it's not hard. It only takes a few minutes, but you got to get trained. You got to know what you're doing.
So, what percent of dentists do you think do what you just said, or use Botox or derma fillers, or use Botox for TMJ and oral facial pain? I mean, what percent?
So I know in our American Academy of Facial Aesthetics, the AFE, we have over 9,000 members and dental members. We have some physicians and nurses there as well. A lot of them have gone through our TMJ and oral facial pain training, and they do it all the time. So it's thousands of dentists. And, from a political point of view, there are only in the United States 300 oral facial pain patients. Say that again. 300 oral facial pain specialists, and I use specialists in quotes because it's not an official specialty by the ADA, recognized or anything like that.
Right, but the ADA is not official either. It's a membership club. Remember when the ADA was telling these dentists in Texas they couldn't say this because they weren't a specialty, and it was the Texas court that said, "Who even are you? You're not a government agency. You're a club. Shut up. Go away." So when people say, "Well, that's not illegal," especially the ADA is not the government. They're not.
Right.
Yeah.
No, I'm not saying these guys are not specialists. These people are specialists, but there are only 300 of them. Wow. Okay.
And what's the website of that? What's the website of that?
What, the oral facial pain?
Yeah.
American Association, I think, of Oral Facial Pain or something like that. American Academy of Oral Facial Pain.
Okay.
But there are only 300 of them, and you take a look at the Journal of the ADA that just came out, and it's sitting in everybody's, in your offices, where 1 out of 6 patients has oral facial pain. Now, you tell me how 300 people can go ahead and take care of 1 out of 6 patients in oral facial pain. In a lot of places, then there's not even an oral facial pain specialist to send them to, right? So dentists need to learn these skills, and they're amazed at how after a few trigger point injections, and there's a real skill and technique to giving them, but after we identify these muscles and you give some of these, pain goes away that the patients have had for years. I mean, I could show you some frightening stories where patients have had both TMJs cut off and put in these titanium TMJs that they came to an AFE member that gave them a few trigger point injections, and their pain went away for the first time in 25 years. So it's really something that we got to do. Physicians know nothing about it. We train a lot of physicians. They know nothing. As soon as the patient says TMJ, they say go see your dentist. And then the dentist gets stuck and is a little bit afraid of what's going to happen next because they don't know what to do with them. So people get bounced around. It's about time general dentists can learn to do these things and really do them successfully, and it's productive for the practice. It's not like it's something that really affects the bottom line there as well.
Louis, you put up three of the most amazing courses on Dental Town: Advanced Practice Management for Dental Practice. The second one, Beyond Drill, Fill, and Bill, treating caries like the medical professionals we dentists really are. Now, the third one, Maximizing Office Efficiency and Time Savings through Operative Dentistry. Is there, and these are, and everybody just loved them. I mean, you really raised the level of our brand of online C. You should do a course on this. You should, I mean, I think a dentist from, hearing you to joining the American Academy of Oral Facial Pain, that might be a big leap. But maybe if you deconstructed it and put a middle step in the middle and had a course on that, maybe an hour online CE would make them jump.
Right, absolutely. I mean, the AFE gives full day, trigger point injection courses and Botox courses and that kind of thing. But certainly it'd be a great introduction. Sure, I'm happy to do it.
You're a saint, and you really are. So is Botox more about TMJ and oral facial pain, or is it more about cosmetics? How should a dentist look at this? Is it more of a cosmetic thing or a TMJ oral facial pain?
So it's really about whatever the dentist wants, because you hit on the two aspects of Botox and what's been going on. And, there's nothing special about Botox. People get all jumbled up, get all excited. Oh, dentists they shouldn't be doing Botox. All Botox is a tool. That's all it is. It's just a pharmaceutical agent that will relax muscles depending on how much you put into it. So it affects TMJ and oral facial pain. We get a lot of dentists that come to AFE courses because that's all they want to learn. The problem is that once you're starting to treat facial muscles that also go ahead and affect the patient's aesthetics, you need to know the aesthetic aspects, because if you put too much Botox into somebody's face, their whole face will fall down and they'll have no control. They'll literally look like they're a Martian because they can't move a muscle. So you need that balance. And then some dentists come in because they want the aesthetic part of it. Pretty soon, though, dentists go right between, because Botox is always used. There's always this blend of aesthetic and therapeutic uses that you need to know both before you go ahead and give it. But it's a great tool for oral facial pain. I've been treating TMJ patients, as you have, as everybody has, for years, and the frustration has really gone out of it, because now there are defined protocols. Here's how we're going to go ahead and treat it. If it works, we know it's muscle-based, patient is happy. If it doesn't work, then we know it's not muscle-based, and then we send them to the physician and to the neurologist and to other healthcare professionals who now take it seriously, because we know what we're doing and what we're talking about. So there's always a blend. There's never Botox only for aesthetics or only for therapeutics. You need to understand and be trained on the blend of the two. But hey, it's whatever dentists like. I mean, Botox for aesthetics has boomed in dentistry. I mean, it's perfect for I don't know how people do aesthetic dentistry really without it, because Botox for muscles and to relax them and get rid of wrinkles, fillers to go ahead and fill things in, and everything around the lips and the cheeks and that kind of stuff. It's all part of dentistry. Instead of talking about it as we have for dentistry in a long time, lip lines, smile lines, and that kind of stuff, now we can actually do something about it, and we can really control the whole thing. So it's great all the way around, but it's important to remember, it's not magic. It's about knowing the muscles. It's about knowing the anatomy. And Botox and fillers are just a tool. There's no reason to get all hyped up and say, oh, dentists shouldn't be doing Botox. Why not? We use a lot of other pharmaceuticals in our offices and in our practices because we're real doctors. We've got to get past this and understand we are real doctors, and it's about time to become that.
See, I think the easiest cosmetic procedure that I do is I just turn down the lights, and it just really enhances my cosmetic. But it's funny because humans are a social pack animal. They're very tribal, and they get very, very mad when someone comes into their tribe and they have a different language, accent, religion, blah blah blah. And what's so hardwired, frustrating about dentistry is when you ask about a flu shot. These patients, grandma's going to the dentist. She may be going to the dentist more often than any of her specialists she goes to. And you try to go to the state board and say, well, can dentists give a flu shot? No. And who stops us? The dentist. It's like, but the pharmacy tech at Walgreens can give a flu shot. They're not even a pharmacist. They're a pharmacy tech. No education. Give them $10, give you a flu shot.
Just hired an hour ago.
But my local dentists at the state board are making sure it's banned for a doctor of dental surgery with 8 years of college to give a flu shot. The other one is oral cancer. I mean, and we're not allowed to give an HPV vaccine. I can't talk to a parent and say, well, your kid's under 12. Let's talk about HPV. It's oral cancer. I mean, I already know 3 dead people from oral cancer, and who's stopping me to give an HPV vaccine? Dentist at the local board. But if you go to the physician and they say HPV vaccine, the doctor isn't even going to give the injection. They'll leave the room, and a nurse or an LPN or a certified nurse assistant comes in. So dentists are always the first ones. They get in a circle. Everybody has an issue. They get one bullet, and everybody shoots one other dentist for one other issue. And at the end of the day, they're all dead. I mean, they're just they need to relax. We need to all work together, like Botox. I mean, who would have guessed that the number one people against Botox would be our own colleagues at the board? Are you kidding me? Really? I have to worry about that.
But let me just tell you one thing about that, because we worked very hard with state boards. Myself, the AFE, we have trained more state dental board members, and it really just comes down to education and just making them really understand. And then you got to tell dentists that it's okay. Your state board says it's okay. So I say this all the time. Dentists have a very hard time taking yes for an answer. Like, they just their minds are just wired to say, everyone told me I'm bad. You're bad to your assistant. You're bad to the front office. You're bad to your patients. You're bad. You're bad. You're bad. Take yes for an answer. My God, now you have the opportunity to do this. I mean, you can. We fought like this for 8-9 years. You can now do this in nearly every state around the country without a problem, for aesthetics, for therapeutics, all within the scope of dental practice. It just came down to educating. And again, we've had more state dental board members take our course than I think have taken any course in dentistry along the line. It's just about education. But you're right. It's frustrating. We're our own worst enemy, and for no good reason. I mean, really, for no good reason.
Only one state, Tennessee, are you allowed to give a flu shot.
Yeah, it's amazing.
49 other states block a flu shot. But you're right, and you've always had the right attitude. You've always been a perfect leader. You're the full pack. You always see the positive. The glass is half full. Where so many dentists, they see the bottom quarter of the glass is half empty. And so that's amazing. So, Louis, I want you to walk us through a patient. A lot of the people listening, podcasts are huge because it's a multitasking behavior. Almost everybody listening to these things are commuting to work. And believe it or not, the average commute of my follower is an hour, which is why we do an hour. But before I have you walk through a patient coming to your office, TMJ, I want to back up a little bit. Why do most TMJ people claim that 85% of TMJ is women?
85 to 90%, because that's what the statistics show. I mean, that's just what the statistics
show. Why do you think that is? Because
they have much more stressful lives. They're multitasking. I mean, God only knows why it is. That's why
I asked you. You are my God.
I wish I had that power. Wow. I wish I had that power to understand.
Do you think it's something as subtle as they have estrogen, we have testosterone, or do you think it's more environmental behavior of career, kids, husbands, spouse? You think it's more environment, or do you think it's something as fundamental as ovaries making estrogen?
I think it's all those things. I mean, literally, I think it is all those things. It's just amazing for that. I'll speak in front of a big dental group, and I'll ask them, who here has got any kind of oral facial pain, TMJ, and that kind of stuff. First of all, it's amazing. Just dental professionals, it's probably, and this is just my anecdotal by looking at all these crowds over the years, it's probably 70-80%, and most of them are women. I mean, most of who we employ are women. So it's just, it's all those things, the reason they have it. But you're right, the statistics are so way out there. I think a lot of it also is, and I know a lot of people think that men are babies, but I think men can be a little bit more tolerant of head and neck pain in terms of they'll just work their way through it. Not so much in terms of other pains around their body, but they'll kind of work their way through it. But you do see a preponderance of women. There is no question about it. But it can affect anybody. It really can affect anybody.
Do you think men don't have it because after their wife has hit them upside the head with a frying pan so many times that all their muscles are loose and relaxed? Okay, so I want you. So they're probably thinking, how does this work? Because you made a scenario. Someone comes in with TMJ, and you're taking an impression, and they should have the pain out now, but you're taking an impression, you're sending it to a lab, you're not going to get it back for a week, blah blah. So I want you to walk a patient in. So my name is I'm a woman. I come into your office and I want to see you because I have oral facial pain. Describe that the average woman patient. What are her symptoms and what are you exactly doing on that first appointment?
Okay, first of all, you are the ugliest woman I ever saw in my life. That's go. Let's get that out of the way right now.
My name's Halweenie.
So let's get that out of the way right now. But it's really the initial entry is no different than any other patient, except you need to take a look at their medical history like you mean it instead of just looking at it. How many patients come into every practice and they check off headaches and the dentist says, okay, well, let's go ahead and make sure, let's take a look at your teeth, and just go right by the headaches or migraines or TMJ and that kind of stuff because, again, they're afraid of it. So you really need to do a good history, and this is done by all of my team members because I like to be doing dentistry. Anything that's delegatable should be delegatable. And that's one of my big things in that Dental Town course you talked about practice management. I mean, use your team. They're intelligent. Train them how to go ahead and do that. So they get a really good history. How long have you had it? Where did it come from? What do you think causes it? What do you do for it? All those different things. So a little bit more. They see headache or TMJ checked off. They're going to have a discussion with them. So I have it all by the time we come in. And then you come in, identify it, point to it. And then we do, in addition to all your dental exams and everything else, radiographs, everything you're supposed to do, we go ahead and do a muscle examination, but not the little muscle examination where dentists go over to the patient and, just poke and feel, okay, as if to say, okay, you really do have these muscles. We've got to identify the pain. And not only that, we want to try to recreate the pain in the office. And the way we're going to do that is really push on muscles that, everything from the shoulders on up. Okay, so this is a really good muscle exam. How hard are we going to push on these muscles? And again, a lot of patients will go, a lot of dentists will go, a lot of dental professionals go, yeah, it's right here on my shoulder, like it's right here. So they're pointing you to where the trigger point is. So what we're going to do is we're going to go ahead and do a really good trigger point examination on these muscles by, and you can do this yourself, Howard, anybody doing this, but if they're listening to this and they're driving, don't do this while you're driving because you need two hands, but take the palm of one hand, take your thumb of the other hand, push against that palm till you actually blanch the skin and then let off. And that's about 6 to 10 pounds of pressure, okay, or 4 to 8 pounds of pressure for about 6 to 10 seconds. I'm going to really push on that. And patients are going to say, when I'm pushing on their trapezius, if it's a recognized trigger point, they're going to say, yeah, I feel that in my jaw. Okay, trigger point pathways literally are these pathways that were identified by Janet Travell, MD, in a thick book years ago. So we just follow a classic trigger point pattern exam. And if we can recreate that pain, then we know exactly what muscle is causing it. And then we'll go ahead and we'll do a trigger point injection. Typically with Botox, you can do it with lidocaine, but the trigger point injection is to go ahead and get rid of that. And literally sitting in the chair, if you've identified it and it's real, the patient's pain will start to go away. So you can recreate the pain and you can make it go away. And then I'll do this all in one appointment because this will show the patient that we can really do something. Then you get into the bruxism appliances. But one important aspect of this is, again, we're into total treatment. And what we teach a lot of is dental sleep. Now, a lot of dental sleep causes bruxism. A lot of bruxism is tied into TMJ and oral facial pain. So we will, before they leave that day, they're coming in for treatment and we get rid of some of their pain, they will go home with a bruxism and home sleep monitor. And this is distributed in dentistry by StatDDS. So the StatDDS bruxism and sleep monitor. And they're going to take an overnight sleep study, but it's the only one that also measures bruxism. Because bruxism affects 1 out of 3 patients, right? We know that for years, okay? The studies go back years on that. And it's the only thing, it's the most common dental disease and the only thing we don't measure, okay? I mean, you wouldn't treat perio without a probe. You wouldn't treat endo without an x-ray. It's the only thing we don't measure. Now we have, with technology, the capacity to treat it. And you don't only check for sleep. Sleep is amazing. The whole dental sleep medicine thing, which we're all for, which we teach in the AAFE all the time. But it's amazing. it's a medical disease that requires a medical diagnosis. No dentist can go ahead and treat sleep without that medical diagnosis. And yet, what we're testing for it? Well, I'm going to suggest you test for bruxism in sleep because I can treat bruxism and I can diagnose it. And now I can talk to any sleep provider. But we find a lot of patients with TMJ oral facial pain have bruxism. A lot of that bruxism comes from airway issues that are sleep issues. So it's really the whole package together. And then by the time you're done with that, if I'm injecting them in the face because they got some trigger points and I'm using Botox, I got to make sure they look good. So really the mantra in the AFE is make your patients look great, feel great, and sleep great, and not necessarily in that order. So I'm going to evaluate their TMJ oral facial pain. It's related to sleep. It's related to their looks. It's related to bruxism. So I'm going to do all that. But now it's a systematic protocol that I'm going to put the patient through instead of just guessing here and just guessing there. That's got to go out the window. You can't just be making bruxism appliances for patients without knowing what you're doing, without a plan here.
And if you just treat the bruxism and you're not getting a sleep diagnosis, the sleep apnea can be dangerous for them. I mean, you can die from sleep apnea.
Absolutely. But most bruxism comes from sleep. That's the amazing thing here.
You said there's only one monitor that can measure bruxism and sleep, and you said StatDDS. Is that www.statdds.com?
That's it. It's the only one.
One T, STAT, just one T, StatDDS.com?
Yes, just the way it sounds. StatDDS.com.
How much is that machine?
That machine's $5,000. The cost of any home sleep monitor is what it is.
Dennis won't buy anything unless it's $50,000 to $150,000. So
I'll tell them to go raise the price.
If they raise the price of that to $150,000, they'd sell 10,000 of them tomorrow. Dennis would, but 5,000. They're like, if this thing had any value, it'd be worth 100,000.
Ain't that the truth?
So who? How long is StatDDS been? Tell us about that. What city is that at? How long has that been out? Who's their key opinion leader, Dennis? To tell us the StatDDS story.
Right, I'm probably their key opinion leader because.
Well, then how come we don't have an online course on it from you?
Yeah, we can.
Would that be part of your Botox, TMJ, oral facial, StatDDS? Would it?
It's what we call in the AFE, we call it the circle of treatment because they're all related. Facial aesthetics, facial pain, and sleep are all related into one circle. And I don't care. So many patients come in at different parts of that circle. If they want to look great, I'm a dentist. I can help them because I've got Botox and fillers. If they come in for pain, I can help them because I got trigger points and Botox. If they come in and sleep because they snore a lot and they heard that there's an oral appliance, I can help them. But they're going to come into that circle and they're going to be part of everything because it's all about looking great, feeling great, and sleeping great. They're all related. Because if you don't sleep great, you don't look great. You don't feel great. If you don't feel great, you don't look great, and you're usually not sleeping great. So it's all those different things together. StatDDS is a dental company that pretty much grew.
What city are they out of?
What? They're also in Cleveland.
Oh, they're in Cleveland.
Yeah, they're in Cleveland, and they pretty much grew on the ankles of the AFE as the AFE started growing, and the AFE needed Botox syringes and this and that. I mean, a group of young entrepreneurs have now, the AFE's gotten so big, knock on wood, that, they're servicing a lot of the AFE members. So, there was a need for a bruxism and sleep monitor, so they're the distribution company for that. There is a need for PPO management, and their service companies, Medicare enrollment, they do that. I mean, we could spend literally an hour on about 10 different topics, over the next year if you want. For that. And now, the AFE is getting into implants, teaching general dentists once and for all how to go ahead and do implants. StatDDS is going to be, they'll be the distributor of products for implants and that kind of thing. So that's how the growth of that company has come along, pretty much on the ankles of the AFE and everything that we do as an education company.
And you know what's so funny? You know how many times I've had this conversation where dentists, when you talk about sleep apnea or whatever, they roll their eyes and they said, there's no market for that. You'll spend all your time and there's no market for it. Then I'll say, oh, well, do you know so-and-so who's 5 miles from your office? And he's like, no. I said, well, now that's all he does. He's full-time with that. He doesn't do root canals or anything else anymore. He's a full-time sleep apnea. So, I mean, there are so many dentists who now only do this. while there's dentists across the street who don't even want to learn it because they say there's no market for it. I'm like, dude, in your state, there are people that now just specialize in this, and that's all they do. And you
Right.
just said your association has 9,000 members.
Right. Now,
So
and so I'll tell you, my opinion on this whole thing is dentists can do whatever they want to do. They can do whatever they're successful with. For me, the way I like to practice is I like to do a lot of things in the office. So me personally, I don't want to be a sleep-only practice because I like, you know, doing crowns, bridges, implants. I like doing that. I like doing some Botox. I mean, you know, it's like the dentist that told me that, I don't know, you know, I learned to do Botox. I can't find a patient. Man, it's the #1 aesthetic procedure in the world, and you can't find a patient? How about telling some women in your practice that you do it? I mean, 95% of women do all the aesthetics in the world. I bet you can find some, you know, what can I tell you? I mean,
and it's also interesting how the
Yeah.
dentists doing the most Invisalign usually are the ones that are doing them first for free on their hygienist and receptionist and assistant. And then when the person says, well, you know, can you wear the tray at work? And they're like, I'm wearing my tray right now. And, you know, so the dentist should be able to get, if he's got a couple of assistants, hygienists, receptionists, spouses, wives, sisters, in-laws, it's like people who don't have one positive Yelp review. I'm like, dude, don't you have a mom or a sister? Really? Nobody loves you on earth. You
That's
can't
right.
find one buddy from college. Nobody will write you one good Yelp review. I mean, what went wrong in your life when your own mother won't write you a Yelp review?
Because some dentists think it's unethical to actually ask the patient to write a nice Yelp review. That's not unethical. That's good business. People ask you, people ask me and you for Yelp reviews and all this kind of stuff. It's just so funny the way dentists are. But you're right. There are lots of sleep patients. There are 40 million people there, and 90% of them are undiagnosed. But you're right. The challenge is, you know, sleep is a medical diagnosis. So the AFE model, and the model that really I teach so much, is go through it through bruxism. That's, by the way, dentists are much more comfortable with bruxism. There's a, you know, most bruxism is related to sleep because of airway issues, nocturnal bruxism. Then let's do something we're comfortable with. Let's test for bruxism at the same time we're testing for sleep. That keeps you within the scope of practice so that the state dental board can never call you and say, hey, I hear you're only treating sleep. You're diagnosing sleep. You're in trouble. You're practicing medicine. No, I'm practicing dentistry because I'm also measuring bruxism. So we have a huge different take. Listen, a lot of dentists have been trained on sleep and they've done nothing with it. And, you know, they've made investments of $20, $50, $100, $150,000, just like you said. They love to make those big investments. You got to do something with it. Not that a big investment is bad, okay? Don't ever hear me wrong, just like you said. But you got to know that you're the right practice, you're the right dentist for it. You know, you're going to go ahead and use it. But to get started, you don't need anything more than a $5,000 investment and then, you know, just getting trained on it. And then you can see it's for you. And then you can see. But for us, we see a lot of interplay between TMJ, bruxism, sleep, and facial aesthetics and dental aesthetics. We see this all the time. If you're not looking, you're right. You're never going to find a sleep patient. But once you learn how to look and understand it, it's all about education. And this is exactly my point about us really being doctors. Because the truth of the matter is, physicians know nothing about TMJ. They know very little about sleep. So we can really be leaders in this healthcare field.
I hate it when you spend a lot of time learning something and don't do anything with it. Like I read an entire book on veganism, and you know what? I didn't do anything with that information. I want you to start with how does this machine measure sleep and bruxism, and then I want you to talk about what is the connection between sleep and bruxism. How does STAT DDS measure that, and how is sleep apnea related to bruxism?
So it's pretty simple. I mean, you know, and all of us, you know, deal with airway. And here is where I'll get to a bruxism issue in just a minute that I hope will scare the pants out of every dentist that's going ahead and listening to this. Okay, sleep issues, obstructive sleep apnea, that's the big one that everybody talks about, OSA. And all that means is when people fall asleep, their tongue falls back, it blocks their airway, they don't sleep, brain's not getting, oxygen's not getting to the brain. Okay? And they'll wake up 20 times a night. They won't get good sleep because they're not getting oxygen. I mean, that's pretty much it. And they wake up in the morning, they're very tired, they're very sluggish, they're irritable, all the things like any human being almost wakes up in the morning with. But a lot of people have this problem of obstructive sleep apnea. Now, how does bruxism, let's get to how it's related, and then I'll tell you a little bit how this monitor works. Why is bruxism related to sleep apnea? It's pretty simple. What's the brain's mechanism for getting people to sleep? No. What's the brain's mechanism for getting people to open their airway when they're asleep? Okay, you fall asleep, your airway's blocked, oxygen's not getting to the brain. The brain sends all of its signals to the masseter and temporalis muscles. You remember those muscles? That's all dentistry, right? To say, move the jaw forward. You got to open that airway, because one way to move the jaw forward, and everybody's been trained in CPR, is the jaw thrust, right? The neck extension, jaw thrust opens the airway, and the patient literally, if they have obstructive sleep apnea, will take this rescue breath, like all of a sudden. Then they'll fall back asleep, they'll stop breathing, jaws will start moving. Now, you and I know that when the temporalis and masseter start moving the jaw forward, that is technically called bruxism. And people can do it 100 times a night, and they can do it, they can really do it very aggressively, as you know, because these are two of the biggest muscles in the head and neck, and they produce a lot of force. Now the patient wakes up the next morning, wakes up and their jaw hurts. They come in the dentist's office, and the dentist says, oh, what's the problem? Oh, my jaw hurts here. Oh, you must be bruxing. Here's a bruxism appliance. Never asks about sleep. Well, if it's coming from sleep, then you need to know that information. You also need to know how many times a night they're bruxing to really see if it's destructive here. So, well, let me just give you the nightmare scenario that we found a lot. Then I'll tell you how this test works. The nightmare scenario that we found all the time is patient comes in, says, my jaw hurts. Well, you must be bruxing at night. Well, why do I brux at night, doctor? I don't know, because at night your brain's asleep and, your jaws just go crazy. And you may have an occlusal interference that's causing, your jaws to go crazy at night for that. And then makes them a bruxism appliance. Well, if they make them, now their bruxism is clearly coming from sleep, many patients. If you make them a bruxism appliance that shoves their jaw backwards, like an anterior plane appliance, you have now just done what to the airway, Howard? You've closed it more, right? So now they go back home, they're wearing this appliance, now they're really uncomfortable because they're getting less oxygen at night. You've closed their airway, not opened their airway, because you didn't know. I'm the dentist, I didn't know. What do I know about the airway, right? We can't claim ignorance anymore. So before you ever make a bruxism appliance, this is the way we teach it, because this, at this point, you're getting to the point where this can be called malpractice already. You go ahead and you test them for bruxism and for sleep, and you see what the issue is. All this is a monitor, sits across their chest, couple of belts, very similar to other sleep monitors, but it's a medical grade. They use this monitor at the Mayo Clinic, at the Cleveland Clinic, at really big sleep laboratories and medical centers around the country and around the world. And there's also an EMG patch that goes to their masseter muscle. So all night, patient presses a button before they go to sleep on the unit, and it measures their sleep, but it also measures how many times they brux a night and how hard they are bruxing. So it measures both the duration, the intensity, and how many times they're doing it. Now I have some objective data. Everybody goes crazy with evidence-based, right? Well, now I have some evidence-based data on this patient. I've measured their bruxism. And now whatever treatment I do, now, by the way, go straight by the numbers. I can certainly do a course on, for Dental Town on this. You go straight by the numbers. If their numbers are this much bruxism, this is the kind of appliance you make for them. And this is what you should be doing. Should you be doing Botox or TMJ? There's a whole list. StatDDS has a report that they give to doctors based on the readings of this monitor, that they do this, because that's part of the service they provide for the people that have this monitor, that will tell them, this is how much the patient is bruxing, this is the kind of appliance you should go ahead and use for them, these are the appliances that are not good for them, these are the kind of restorative materials that can withstand their bruxism, and you should consider this treatment option, this treatment option, this treatment option. So now a dentist sits down with the patient, they have got an objective, evidence-based report on that patient that the patient looks at and is much more likely to go ahead with treatment. So that's pretty much how that works. But the patient takes home this monitor, wears it at night, brings it back the next morning, and in our office, and I know many AFE member offices, they bring it back the next morning. It's got to be by like 9, 10 o'clock, because I got the next patient that this is going out with. We have many AFE member offices that have 4 or 5 of these monitors. Like you said, I guess they wanted to spend at least $25,000, right, before they got serious about it. But we've got, they're really cooking with this. But they're doing better dentistry because they've measured the bruxism. I mean, it's pretty much that. How many times do you like it when an implant fails or a crown fails and we say, well, the patient's bruxing? Well, great. Do so. How do you know they're bruxing? How much are they bruxing? How do you know if you did something for that bruxing that it's working? Now you can measure it just like you can measure a perio pocket.
So is this, for the bruxism part, is that pad attached by a wire? Does it go to one side of the face or two?
It's an EMJ patch, one masseter, and it leads right into the monitor. And the monitor is pretty much a hard drive, and the software just measures all the bruxism at night. And it's amazing when you see these reports, because you can literally see when they brux at night. Many times it's directly related to when they have an apnea, when they stop breathing. And then the brain says to the masseters, start grinding, right? And then you see this huge spike of bruxism. Then they start breathing again, and it repeats itself 20, 30, 100 times a night. So now this takes out the mystery of, a patient that comes in and says, yeah, my neck, my jaws are hurting. Well, why are they hurting? You must be bruxing. Oh, you must have an occlusal interference. I'm not knocking occlusion, okay? I'm all about occlusion. We do that all the time. But some of this nonsense that we've had that has got no evidence behind it for years, that, people have bruxism and TMJ because they have a few occlusal interferences. Not that. I like occlusion because it saves my dentistry, right? I need it for good dentistry, but it's not the cause of orofacial pain. That's for sure. You've got sleep, you've got muscles that are much more the cause of TMJ and orofacial pain before that. But our big thrust in the AFE is measure the darn thing. Why are you even making a bruxism appliance when you have no clue what you're doing? We don't guess at anything else, right? We don't guess. So we'll go ahead and try to, patient will say, it hurts somewhere down here, and we'll be measuring and knocking on teeth and doing, ice cold tests on teeth to find the right tooth. We don't go ahead and do 5 endos. Well, unless you want to build your practice, you can do 5 endos. But, we don't do this in any other aspect. It's about time we become real doctors when it comes to bruxism, TMJ, sleep, and you'll do better dentistry. Because if that patient is bruxing, whatever you put in their mouth has no chance of survival, and that really frustrates dentists too, right?
I think the occlusion people are funny because if you listen to their religion, it's like, well, doesn't an orthodontist blow out the Curvis P, the Curver Wilson, take him from canine guidance to group function? I mean, we have 10,000 dentists called orthodontists doing everything the TMJ people say will not work. And, so yeah, there's something more to it than how the teeth touch down. So Louis, do you charge the patient to take that monitor home? Is that a cash deal? Does insurance cover that? What is it? I mean, if you buy a $5,000 machine, you come into my office, I send you home with is there a fee for that?
So that's a great question. So, AFE members have used different models. The model I always use in my practice is I don't charge a thing for this, okay? Because, first of all, the consumables to go ahead and do the test, once I own the machine, and you can rent the machine, FatDDS will rent the machine so that you don't have to have a big cash outlay. You can buy the machine, it's whatever you'd like to do for that. So for one of my offices, I think we rented. One of my offices, we actually bought the machine. But it doesn't matter. For me, I'll tell you my model, and you can charge for it. You could try to charge medical insurance. To me, it's just not worth it. I like to open the doors. I'm going to test everybody that I think needs testing for less than $20 in consumables. That's what it cost me to do the test. Hey, listen, I'm an experienced dentist, as are people listening to this. You know if the patient's bruxing. You can see the evidence the patient is bruxing. Okay? And how many times do you tell a patient, hey, you're bruxing, you need an appliance? And the patient says, nah, I'm not bruxing. I'm just fine, right? He's got these tiny little teeth, and he can chew steak with all of his front teeth with no problem, and you tell you he's not bruxing. Well, you know what? Let's measure it. And I'll just give him that to take it overnight because it's going to give me data to do more dentistry. I know I'm going to get at least a bruxism appliance, which is $500 to $600 in our offices, and that's pretty much a national fee. I may get an oral appliance, which is $2,000, $3,000, $4,000. depending on the appliance I'm making for them. It has boosted our production like crazy. I'll tell you something really interesting, and it's something that we could do because we're a membership-based organization, the AFE, and because we teach these skills, we've been able to measure, like dentists that have gone ahead and taken the AFE bruxism sleep course, TMJ, and Botox and fillers. We did a member survey of people that have been doing these services for over a year and a half. Okay, only those members that were doing these, and they boosted their practices by $26,000 on average a month. Some more, some less. A lot of that, we have some, and then we did oral appliances, we did just Botox, we did really put some of this out. Oral appliances, I mean, in my own office, we've quadrupled the number of bruxism appliances, just bruxism appliances, just by testing people. And now we're doing anywhere between 5 and 10 oral appliances a month, depending on the practice and the associate. We have AFE members that are doing 25 appliances a month because they've got 4 or 5 units and are really chugging this out. So I like to not charge pay. I don't want to give them a reason to say no. I know this is going to end up in the bruxism appliance at least, if not more dentistry, oral appliances. I mean, I'll just say this. I don't do an implant case without checking the patient's bruxism. Who in their right mind would put in 10 implants, 5 implants, 3 implants without knowing how much the patient bruxes, if and how much they brux? I don't do a case of 3 units or more without checking bruxism because I don't like failures, neither do you. I hate failures on a 10-unit case, right? That's really frustrating. Let me take bruxism out of the equation by measuring it, treating it before I go ahead and do it with occlusal equilibration, with all the other stuff. It's a simple overnight test. I mean, it doesn't take any time in your office. You teach the patient how to do it by a YouTube video or by auxiliaries. They give it to you the next morning. Now I've got real data on this patient. So it's changed the way we practice dentistry, certainly in the AFE and certainly in my own practice.
You know, I think I think a big thing that Stat DDS should do is find out how many units they've sold to how many dentists and how many of them went back and bought a second machine, because I know several dentists that do now have like 5 of them. I mean, if that's not proof that this can work in somebody's office, I don't know what is. I want to ask you a couple questions. You still see debates by dentists and hygienists. You have a lot of hygienists listening today that when they see abfractions, they think it's from the toothbrush. Do you
Right.
talk about the difference between abfraction from a toothbrush versus bruxism grinding?
Right, and or GERD or any kind of acid reflux and that kind of thing. It's funny, and I always only with you will I say stuff that's politically incorrect, because you and I we can talk to each other like the brothers that we are, right?
Right.
Evidence-based. Listen, abfractions is a great example of this. When you and I were in dentistry and growing up and in dental school, abfractions with toothbrush abrasion, that's what's causing it. It was evidence-based science. Everybody accepted it, right? I mean, there were studies up the wazoo. How in the world did we ever believe that abfractions come from toothbrushing when nobody brushes their teeth? I mean, really, no. I mean, you would think that patients are such great brushers, they've actually wiped away tooth structure. It's pretty much ridiculous. I used to believe it a lot, but when you start,
Well, you know who corrected the dentist? You know who corrected the dentist on abfractions?
Who?
It was the veterinary dentist. They're like, dude, we see these on all the animals and they don't have toothbrushes. It was actually veterinary dentists that corrected us. I want to ask you another question. Sometimes dentists get a little anal, but they get mad when you say TMJ because they want TMD. Well, how does the American Academy of Facial Aesthetics solve this issue that the B2C consumer market, they branded TMJ, and then the anally retentive dentists are saying, no, it's TMD. So is it TMD or TMJ on your website or social media?
We call it TMJ. You know why? Because that's what patients call it. And,
Right.
I'm going to talk the patient's language. That's ridiculous. It is a funny thing. I got to say, TMJ is a part of the anatomy. But it's now we treat it. It's the word for the disease. Like, if you go to a doctor and you say, I have a knee problem, you don't say to the doctor, I have knee, right? Of course I got knees, right? But TMJ has become the disease. But it's the way patients talk. Of course, talk that way to patients. You're right.
The
No,
American.
what you mean? It's ridiculous. It's called TMJ in the consumer. It's amazing. I got to tell you, the AAFE, the American Academy of Facial Aesthetics website, facialaesthetics.org, is really built for physicians, nurses, dentists. There's components for everybody. Certainly, it's big with dentists because everything we do in dentistry. But I can't tell you how many consumers come to that site. It's incredible looking for information. And of course we call it TMJ. Why? Because, and I've heard that from dentists sometimes. I've heard it, derogatorily, well, of course, the AFE calls it TMJ when it's really TMJ. What, are you kidding me? I'm trying to build practices. The only way to do that is talk the patient's language. You've said that many times where, a dentist will be, with their radiograph up against the screen, talking to the radiograph, telling the patient, well, you've got this and this and this, and using all kinds of technical language. It's ridiculous. Okay, that's just a ridiculous way to think about it, but dentists will be dentists, right, Howard?
What percent of dentists do you think are so anal you could sharpen a number 2 pencil in their rear end?
That's
Yeah.
automatic, right?
Automatic, yeah. But you're right. You gotta speak the language. By the way, what are your thoughts on GERD? Since you opened that can.
Oh yeah, certainly something that you need as part of your medical history, and it's something that if you see, it's gonna dissolve teeth. And why would you put in a bunch of restorations, a bunch of crowns, where GERD gets to the margins and eats away at it? Certainly, it's something that the patient needs to address.
You know what I heard from the holistic alternative people, and I tried it, and it absolutely worked on a patient. Is it's so counterintuitive, but a shot of vinegar before you go to bed into your stomach, and then in the morning they wake up, and instead of regurgitating and gagging and brushing their toothbrush and gagging, and I swear patients swear by it. Just apple vinegar, a shot of this. You would think that acidic, nasty tasting vinegar would actually make you just want to throw up, and I swear patients swear by it.
I'm good for whatever works. Okay.
Yeah.
Scotch or bourbon for me, but I'm good for whatever works.
We need to come out with a vinegar made by Jack Daniels. But I'm telling you, that is amazing. Louis, you are so amazing, and you're always so upbeat, and you're always so full on fire. I really hope you make this online course because to explain the stat, DDS, how that works, the bruxism, the Botox, the facial aesthetics. I don't. Are you going to be able to do that in an hour online course, or do you think that's going to be 2 hours, or what do you think?
It can be whatever we want. It can be a series of courses. So I'm.
Are you up for that?
Yeah, absolutely. I do it all the time. I'm really happy to do it for you.
You are an amazing man. You're just an amazing man. Anything else you want to close with? Why is Cleveland? I mean, they got the Cleveland Clinic. They got you. What is it with Cleveland and research-based science?
And we got LeBron. Don't forget about LeBron. We got basketball seasons coming there again. Cleveland, we've got a very, very strong medical community here. So it's something that I've been proud to be a part of for a long time. But it really does. There's a ton of research where we keep building new hospitals and research centers. It's real. I'm on the board of a medical foundation that just gave a $10 million grant. Case Western Reserve Medical School is building a brand new school, medical, dental, nursing all together. So we're really into integrated medicine, medical sciences and that kind of stuff. So just my upbringing, but certainly we've really patterned the AAFE along those lines, really bringing everybody together under the same umbrella, because it's amazing how much we as dentists can learn from physicians, but even more amazing is how much physicians learn at dentists at our courses. I mean, they are just blown away. I mean, at a TMJ and oral facial pain trigger point course, we will have a general dentist, sitting and standing next to a neurosurgeon who's coming to learn how to do trigger point therapy, and they talk like they've been buddies because it's funny. Physicians can look at dentists and say, hey, these guys really know what they're talking about. But like you said, other dentists will look at dentists and say, you got to stop doing that. We're just teeth mechanics and that kind of thing. So we're all into that in Cleveland. So certainly it's the philosophy of the AFE as well.
These podcasts are always listened by someone's downloading it from all 206 countries. Tell the international viewers, you're on one of the 5 Great Lakes. You're at Cleveland, Ohio. What lake are you on?
Well, we're on Lake Erie.
Lake Erie. And does that freeze over to where a car could drive on it in the winter or not really?
We're not quite that cold, but we're in something called the snow belt. So that lake acts as a snow machine sometimes. So you could wake up in the morning and have 2 feet of snow because of the lake action on there. So and that's why I travel so much in the winter giving courses, because I hate being here in the winter. I'm getting too old to fight that snow.
Well, I remember one of the greatest dinners I ever had. I was lecturing in Cleveland, and some dentist came up to me and goes, you fly out tonight? And I said, no, first thing in the morning. He goes, what are you doing for dinner? I said, no plans. He goes, you want to come to my house? My wife makes the best spaghetti in the world. So I said, okay. He lived on the lake.
Yeah, right.
That was the most beautiful view. We sat there on the porch eating spaghetti, killed a bottle of wine. I mean, it was just, my God, that was gorgeous.
Cleveland is a great place to live. So, and it's a great place for sports, even though we never quite do as well.
And what's the bigger town?
Ohio State Buckeyes, so our Buckeyes keep us interested.
And what's the bigger city, Cleveland or Cincinnati?
No, Cleveland. Well, at least in Cleveland's eyes, Cleveland's a bigger city.
It's a bigger city? Okay. Well, hey, we're out of time. It's been an hour. Louis, thanks for being, you've been an idol of mine. I mean, we've lectured at the same convention so many times the last 25 years, and I just think you're just a hell of a guy from A to Z. I do. I just think you're a role model from A to Z. I love your amazing mind. The books behind you explain it all. Thank you so much for spending an hour with me today.
All right, right back at you, Howard. You really appreciate it. We'll see you again.
And tell your lovely wife I said hello.
Okay, I sure will.
All right, bye-bye.